Mute on. Good morning and good afternoon, everyone. My name is Carla Williams, and I'll be moderating today's call. On behalf of my CPSI colleagues, Ann McLaurin and Karina Ganton, and our guest panelists, I would like to welcome you to today's webinar. Hospital Harm Measure. Can it really be used for improvement? Please note that today's webinar will be recorded and will be available on the CPSI website on Monday. The link to the recording will also be sent along to you via email. Before we get started, let's review a couple of the WebEx tools we'll be using during today's webinar. So while the phone lines are blurb there with chat in it, click that and it will open the chat box for you. Simply type in your comments or question here and be sure to click send to all participants to make sure we don't miss a thing. We'd also like to get your feedback on a couple of things. And to do that, we ask that you go to the top left-hand corner of your screen and you see a little annotation marker there. When you click into that, a menu will drop down and you will see a pointer.
Carla, sorry, we're just having a little bit of a hard time hearing you. If you could just maybe speak a little bit closer to the phone or something. Just sounds like you're a bit far away.
Thank you, Karina, and I don't know that my volume was up fully on my phone. Is everybody able to hear me now?
Yeah, that's great. That's a lot better.
Okay, and I can barely hear you, Karina, so there could be an issue with my phone, and if that's the issue, I do apologize. So I think what I'll do is just go back, or did, Karina, everybody hear the first part of the introduction there?
The introduction was great, just the instructions for the annotation, this particular slide.
Okay, thanks, Karina. All right then. As I was mentioning earlier, we would like to get your feedback during the call, and to do that, we have the chat box there in the bottom right-hand corner. Just simply type your comment or question in here, and when you do so, be sure to click send to all participants because we want to make sure we capture everything. If you're not seeing the chat box right now, just go to the top right-hand corner and you see a little chat blurb graphic. Click into it and your chat box will be opened. Also, we want to use some annotation in this call. So to do that, just go to the marker in the top left-hand corner of your screen, click into this button called Annotation. Then a drop-down menu will appear and you will see a pointer or arrow. And when you click it, it will enable you to show your pointer or arrow. So let's just try that now. Use that arrow to indicate which picture reference here best reflects your role. And if you don't see something that reflects your role, just click on Other. Great, we have a lot of patient safety improvement people on the line today. It's great. Wonderful. Do we have anybody from Health Records other than Lucy? Lucy, it looks like you may be all alone here today. Wonderful. Thank you for that. The first report on the hospital harm measure was released last fall. CPSI has partnered with CIHI on this project and the development of the Hospital Harm Improvement Resource. We'd like to get a sense of where you are currently with regard to this work. Again, using your pointer, please indicate which statement best describes your current hospital harm measure related experience. Wonderful. Good for you, Laura. Great to see. So we're clearly at different points along the continuum. Okay. Great. It's good to see that we're all on the call today. I'm hoping we will learn something. Thank you. Well, our goal today is that you will leave today's webinar with at least one practical idea for using the hospital harm data and or the hospital harm improvement resource to help inform your QI plan. And to do that, here is an overview of today's session. As you will see here, we have a great team of panelists presenting some thoughtful insights today, and we're glad that you're on today's call with us. Our first presenter today is Donna Davis. Donna has been the past co-chair and is a current member of Patients for Patient Safety Canada. Donna has spoken internationally on the subject of patient safety. To do that, she is able to draw from her many years of experience as a nurse. But more so, she draws from her personal experience of losing her 19-year-old son, Vance, to an adverse healthcare event. Over to you, Donna.
Thank you very much, Carla. Is everyone able to hear me?
Yes.
Okay. Again, thank you, Carla, and thank you to everyone across the country who took time out of your busy day today to join us for this webinar on the CPSI and CIHI collaboration of the Hospital Harm Measure and its improvement resource. Just before I start, though, I would like to say that I know that we're all thinking of the folks, some of them fellow Canadians, and one of them, a patient safety specialist, I guess I'll call her, Katie Braden, who I met in my patient safety travels. They are facing their own trials and tribulations as they face the recent and present hurricanes. So I know our thoughts are with them all, and we hope they all stay safe. Could you put up the picture, Carla, that I sent of Vance? By the end of today, 378 patients will be harmed by the care intended to help them. By the end of this year, 1 in 18 hospital stays will result in at least one harmful event. And of those 18, 1 in 8 will end in the death of the patient. On April 1st, 2002, our 19-year-old son was one of the 378 patients harmed. He was one of the 18 hospital stays that had a harmful event, and his was the 1 in 8 harmful events that ended in his death. Since the validation, some 5.5 years after his death, that the care Vance received, or rather the care he didn't receive, contributed to his death, our family has strived to ensure that lessons learned from Vance's death are shared so that another patient isn't harmed similarly and no family has to go through what we have gone through. We cannot get back what we lost, and we can't undo what has been done, but we can work together to ensure that every patient is safe. The Hospital Harm Measure and the Linked Resource Improvement Tool is another in a long line of things we can do to ensure that harm while receiving care doesn't happen. Why is this tool important to families? Look at the 4 main categories of harm: infections such as surgical site infections, C. diff, which resulted in the death of many seniors in Ontario a few years ago, administering the wrong medications, or care that resulted in pressure sores or misdiagnosis, as in Vance's case, procedure-related harm like bleeding following surgery, and patient accidents, traumas like falls. Some on the call today may have firsthand knowledge of one of their beloved elders falling while in long-term care. Most of our Patients for Patient Safety Canada members have themselves or their loved ones experienced the harm in the categories and subcategories contained in the report. So yes, it is important to us. The Hospital Harm Measure collects data on how often these events are happening in your organization. When providers know what events are happening frequently, they can be proactive, use the improvement tools linked to the measure, and take action to prevent the harm. It is important for organizations to embrace and learn about this measurement tool and resource. We wouldn't send a surgical team with only part of the equipment needed to do their work in the OR. We can't expect good outcomes in care across the continuum without all the tools to keep patients safe. Linking caregivers with the tools they need to keep their patients safe and to keep families whole is so important. I can't tell you how much it means to me and to other patients and families. Wouldn't it be wonderful if common knowledge, that is, the common knowledge that harm does happen in healthcare, could become knowledge that is common. I mean using the hospital harm measure and its linked improvement resource to keep every patient safe. We have come a long way. Just to be acknowledging that harm happens and to talk about it is a vast improvement from years past. Even in 2002, when Vance died, no one wanted to mention the word harm. It is a relief to be able to talk about it and not hide from the facts anymore. I believe in the hospital harm measure. I believe in the improvement resource that goes along with each of the 31 indicators. More than that, I believe we have a health system filled with people dedicated to the goal of reducing patient harm while receiving care and realizing the vision, Patients for Patient Safety Canada, every patient safe. I've told my son's story many times over the years. One of the things that makes reliving it a little easier is knowing there are people in our system who care and who want to make a difference. People like the team from Fraser Health, who you will hear and learn from shortly. I want to thank you all for your dedication and for the job you do for patients and families. We really need you. I would like to share with you in closing a poem that was written by one of our Patients for Patient Safety Canada members, just to show you how important it is and how we feel so blessed as family members and as surviving patients of harm that we are included in these types of webinars and the learnings and the teachings that can be done in patient safety. I have taken the liberty of changing it a little bit to make it my own, but this is from Tanya Barnett, a Patients for Patient Safety Canada member. It's called The Door. Knocking, I stand outside. 15 years I've stood. 15 years I've waited, and I cannot leave him now, voiceless and unheard. I cannot fail him. I cannot let him fail. So here I stand, and stand until I knock and I wait, like all the yesterdays, until wide-eyed I am ushered in. As I cross the threshold, I wonder, had perseverance won, or did resignation reign? Perhaps a little bit of both, but who cares right now, for I am in. We gather at their table, inclusion folding us within its warm embrace, two needed parts of a greater whole, and now, no longer without voice. He who speaks through me, is finally honored well. And as for me, I gently smile, lay down my head, and weep. Thank you to all that are on the call today.
Donna, thank you so very, very much for that thoughtful presentation you provided today and reminding us yet again how critical and imperative it is to have patients involved in every element of our care. You are the voice, and thank you for sharing this with us today and that beautiful, beautiful poem. I'd now like to turn things over to Kevin Hare and Nicole Quilty from Fraser Health. Donna mentioned them just a few moments ago. They've been doing some work using the hospital harm measure and their quality improvement work at Fraser Health. So over to you, Kevin.
Good morning, everyone. Thanks for having us on the call to present to you the work that we are doing in Fraser Health with the hospital harm indicator and the patient resource materials. So I'm here with my director, Nicole Quilty, from Quality and Patient Safety. You'll hear from her in a moment about the tangible work that we're actually doing, but we figured we would start because it's always nice to know who is presenting to you. So Fraser Health is in the province of British Columbia. We are the largest health authority in British Columbia, not by geographic area, but by patients served. We have an annual operating budget of $3.5 billion. We have 12 acute care hospitals, which include breakdown 3 tertiary centers and the remainder community or large community sites. We have 83 residential care facilities encompassing roughly about 10,000 beds for patients. We have 25,000 staff that service those patients and families, 2,600 physicians, and 8,000 volunteers that work tirelessly within our organization to help us provide services. Some quick daily statistics on what happens within Fraser Health is that 42 babies are born every day. We have roughly about 12,000 ER visits across those 12 acute care sites. We have 630 home care visits that happen, and we have 740 clients accessing mental health and community health services across Fraser Health. So we are a large and busy health authority every day that is looking after patients and families within the lower mainland of British Columbia. So Fraser Health's journey since 2015 has been to shift our culture from a reactive harm response process to a proactive harm identification and prevention strategy. Changing a long-standing culture to focus differently on events that can be prevented based on the implementation of evidence-informed practice takes time, commitment, and vision. Here we have an example of basically how we have focused our efforts on basically patients and families, building capacity, financial responsibility or fiscal responsibility, quality, and patient safety. We see these 5 elements as critical to success to the journey in changing our culture within Fraser Health. Our senior executive and executive leadership of Fraser Health has endorsed and monitors our commitment to changing this culture on a regular basis. Fraser Health has taken a strategic and operational position to deliver evidence-informed care to prevent harm from reaching our patients where we can. The sobering fact that we heard before is that 1 in 18 patients within Fraser Health or within Canada that enter acute care facilities will experience a harmful event while in our facilities. And that, when we saw those statistics, we just said that's too many patients. And we need to do something different. So what are we doing differently? We have received support, like I said, from our senior executive and our executive leadership for our strategic and operational imperatives to prevent harm with the creation of a hospital harm. And we have received support in basically preventing harm by the creation of the hospital harm indicators from CPSI and CIHI. HHI has been utilized within Fraser Health in its early days as a benchmark against our patient safety priorities, and then as an area of focus in this year's strategic planning process. The indicators and resources have demonstrated the ability to drive focus for our improvement efforts and ensure appropriate resources and support culture change, implementation of evidence-informed practice, and ultimately the prevention of harm within our health authority. I'm now going to turn the presentation over to Nicole Quilty, the Director for Fraser Health in Clinical Quality and Patient Safety, to provide you with tangible examples of how Fraser Health is utilizing the hospital harm indicator to prevent harm within our health authority. Over to you, Nicole.
Thank you, Kevin. I'm now going to take you through, a high-level look at the process we use to develop our organizational patient safety priorities, their alignment to the hospital harm indicators, and our experience in working with these over the last 2 years. In follow-up to an Accreditation Canada survey in April 2015, Fraser Health embarked on a process from July to October 2015 to identify key safety priorities for the organization that would form an overall quality plan. In addition, we recognized that better alignment was needed between the training provided to staff and the priority safety issues identified in the safety plan to actually improve patient outcomes. Between July and October 2015, a group of clinical and non-clinical staff from a wide range of areas came together for a series of meetings. The intent was to identify the most important preventable patient safety issues that needed region-wide commitment and support to be successfully addressed. Steps to create a safety plan were then mapped out. The first step was to agree on the overarching patient safety aim, which was to minimize preventable harm to patients. Then an initial environmental scan was conducted, reviewing key documents, evidence, reporting requirements, and Fraser Health data sources to identify a range of safety indicators. Additional input was sought from a variety of resources and experts regarding specific Fraser Health safety issues. Each indicator was prioritized and assessed utilizing a risk management approach, applying a risk assessment and risk matrix tool. The list was narrowed down to a select few from which the Fraser Health Executive Committee selected priorities from a list, and an ethical decision-making framework was applied if needed to help with decision-making. For each priority, SMART goals were formulated and framed to include perspectives of staff, physicians, patients, and families. Leads for implementing each priority, measurement indicators, targets, and timelines were determined. Governance and accountability for monitoring and reporting progress was also designated. Resources required to deliver the plan were allocated, and an organizational training plan was developed about the patient safety priority areas. Safety priorities were incorporated into the corporate and organizational quality plan, and departmental work plans were also aligned with these. The primary principle, once again, driving the quality plan was to identify and prioritize opportunities to reduce preventable harm that needed organizational commitment. 40 indicators were initially identified for detailed evaluation from multiple data sources that were further narrowed down to 18 and quantified as to the actual number of patients harmed, and then assessed using a risk heat map to identify which indicators caused approximately 80% of the harm to patients in our organization. As a result of the process, 4 outcome measures and 2 process measures were identified as the 6 patient safety priorities of focus for our organization. Current performance and targets were set for each site and program area, and the overall target was for a 50% improvement. Each priority area, best practices and tools, resources for teams were developed to support practice improvements. Organizational and site report cards were updated to include reporting on the 6 patient safety priorities so everyone could see and track their progress towards the targets. And this is just a recent example from our July report card, and I'm actually pleased to let you know that for August, we actually had all of our indicators in green, so we're very proud of our progress there. To improve awareness, the Patient Safety Starts With Me campaign was designed to bring awareness to staff around the 6 patient safety priorities. Staff would draw or color themselves into the patient safety journey and make a personal pledge to how they would contribute to the 6 patient safety priorities. Research has shown that we remember visual images much easier than words, and spending time on each image allows us to put the image into memory. This was a unique and innovative way for staff to become engaged and aware of the 6 patient safety priorities. This was trialed on a surgical unit in Fraser Health prior to the introduction with very positive results. Staff were asked to post their pledges and take team photos to win a prize for Canadian Patient Safety Week, and to have fun and be creative. The timing of the Fraser Health work to identify the patient safety priorities preceded the release of the hospital harm indicators. But, as you can see, the 6 patient safety priorities are well aligned with the hospital harm indicators. Once available, the hospital harm indicators validated the work and the process of the organization to identify the patient safety priorities, and we continue to use them to benchmark and validate our process and to update our patient safety priorities. Although some indicators were not identified as patient safety priorities, the organization monitors the following indicators closely and works with the team to make improvements in other areas aligned with hospital harm indicators, such as VTE prophylaxis, patient trauma, and more specifically falls and falls with injuries, pressure injury and ulcers, and device failures. And we've actually developed a specific position to support regionally a consultant of clinical supplies, equipment, and practice who's been instrumental in terms of our selection and implementation of clinical equipment and also for supporting equipment failures and recalls. As well, specific groups are looking at other indicators and conducting improvement work focused on some particular program or network areas. This includes our maternal, child, infant, and youth program, which looks at indicators related to obstetrical hemorrhage, trauma, and birth trauma. The Frail Elderly Network, as well as the Hospitalist Physician Group, is identifying improvement opportunities for delirium. The Surgical Network, through information provided through our National Surgical Quality Improvement Program, reviews surgical site infection rates and has recently sparked initiatives related to glucose control, and subsequent to a recently hosted event highlighting glucose control and its relationship to surgical site infections. And the keynote speaker at this event was Dr. Patch Dellinger. When viewed together, this highlights the initiatives underway in our organization and clearly demonstrates the alignment with many of the hospital harm indicators. Now I'd like to highlight some examples of the progress with initiatives in 3 areas of our patient safety priorities. So for UTI, hospital-acquired UTI, this data goes back to 2012-2013 and shows progression over the last 4 years. As you can see, the bars indicate our fiscal year rate per 1,000 discharges, and a nice line that has trended downward over the years. The overall Fraser Health target is 15.7. The overall decrease can be attributed to some of the following: staff education, reduction of catheters, antibiotic stewardship, and removal of incontinence briefs at some sites. While much of the initial improvement work was likely attributed to increased awareness and improvements in catheter care and the reduction of catheter use or time of use, the focus has now shifted to best practices with hygiene and continence care. Some sites have completely changed product usage, moving away from briefs to a briefless 2-piece system. Also, raising awareness with staff regarding the importance of over-treating or treating asymptomatic bacteriuria has been another example of some of the work. We're also working with health information management regarding coding and drawing attention around physician reporting and the importance of accurate discharge summaries. So we have accurate coding. This is an example for pneumonia, so healthcare-associated pneumonia. So again, trending downward over the last 4 years. The target for Fraser Health is 15.6. And currently the focus is on oral care and mobility. So there's an emphasized focus on consistent oral care and ensuring supplies are available on all of our units. And individually, the sites and programs have created action plans that are specific to their the context within their sites and some of the issues that they are seeing. And of course, mobility matters when it comes to pneumonia. We've adopted mobility matters messaging to ensure an increased focus on early mobilization for all patients. There's a multidisciplinary perspective and approach to mobility, which includes the development of mobility plans within 48 hours of admission for all patients. Some units have completed a mobility survey to determine baseline perception of point-of-care staff to inform education planning and assess equipment needs for safe mobilization, reduction of falls, and reduction of patient and staff injury risk. And finally, sepsis. So we only have, as you can see, we only have 2 years of data available for sepsis. The target here in Fraser Health is 4 per 1,000 patient discharges. And much of the sepsis work in Fraser Health has been more recent than the UTI or the pneumonia work. We've had all of our acute care sites have now implemented the pre-printed order set for sepsis over 2016 and leading up to June of this year. Focus has been on the reduction of precipitating infections such as UTI and pneumonia that can lead to sepsis, and the early identification screening tool and use of the sepsis pre-printed order. We still have much work to do with respect to the use of the sepsis pre-printed order set, and a survey of 60 physicians, primarily hospitalists, indicates that there is limited use. So this is certainly an area of focus. We have ongoing work to ensure that there is use of the screening tool, so we are recognizing sepsis early, and again, improving the use of the pre-printed order set. So that brings us to the end of our presentation, and I would like to thank you very much for the opportunity to share our experience with you today.
Hi. Carla, are you there?
Sorry, I'm having trouble with my line here today. My apologies. I just wanted to thank Kevin and Nicole for their thoughtful presentation today. And I couldn't help but notice, as you provided your presentation, the comprehensive approach you took to this in identifying your 6 patient safety priorities. It seems that as we listened, you pulled information from every avenue to build your case, and then you had all levels of your leadership team involved in setting the priorities, building them into operational plans, etc. I'm just wondering, have you any quick insights to share with anybody on the call today? Is how do you start the work? Once you get the information together, who do you need in the room to start building the momentum?
Quick insights for basically how you start this is basically my belief is that the work will pull you. There will be individuals that you will find within your organization that have a distinct passion for this, and the first thing that I would say is leverage those individuals. Because they will stick with you for thick and thin. Strategic planning in no way, shape, or form is exciting or fun. The group that sticks with us is dedicated, and I think that dedication comes from they know the outcomes that we are driving for in reducing harm. So look for those individuals that are drawn by this work to start your committee around strategic planning first and foremost, and creating kind of that groundswell of individuals that would be interested, because people will be attracted to this once they know that you're starting to get traction and that the group is kind of moving forward and breaking ground. So I say start with those interested individuals first, and others will come.
Wonderful. Thank you for sharing that, Kevin. And as well, I would invite anybody who may have some questions to please make sure you enter them into the chat box. We have some wonderful expertise here on the line today through Donna, Kevin, and Nicole, and we want to tap into that. And at this point, I'd just like to turn it over to Ioana Popescu, our colleague at CPSI, and Ioana is the lead for Patients with Patient Safety Canada. We've asked Ioana to share some patient-related tips regarding the hospital harm improvement resource. Over to you, Ioana.
Thank you, Carla, and thank you, Donna, and the team at Fraser Health for a great presentation. It's great to be here today. So my role at CPSI involves supporting Patients for Patient Safety Canada and leading any patient engagement projects that we have here. As part of that, it is my role to support the project team who build out the hospital harm improvement resource and the work that they've been doing. So I've been very proud, we've been very proud to see that in every clinical group of the hospital harm improvement resource, there is a section that talks about its importance to patients and families. What I brought here on the screen is actually a picture of the website for one improvement resource clinical area, just to show you how the patient perspective is brought into every one of the improvement resources. Actually, what we've heard from people like you on the line is that having the patient perspective and why the hospital harm improvement resource is important to patients and families is what makes this resource guide unique and very different than other resource kits or resource guides where the patient perspective is not brought forward. So kudos to everybody who built this improvement resource, and an encouragement to all of you to make sure you scroll through that sub-menu, find the patient story, and use it in your own work. So what else can you do apart from just using what is currently available on the website? Well, I have two ideas for you. One would be to include a patient and family experience, just like we've done by inviting Donna here today to be part of the webinar in all you do. On this slide, I have two screenshots. I'm just trying to make it easier for you to see where to go and what to get, with hyperlinks to each of them for how to include the patient story in your work. The first document is brought to you by Patients for Patient Safety Canada, and it was created as a result of a webinar where we discussed on how to share your story. So read that and share that with your patient and family advisors or partners before they prepare to share their story. And the second one is from a different webinar where we found a resource from In60 in Manitoba. It's a cancer group where they have a guide on how to present a patient story at a board meeting or in any circumstance like that, what questions to ask after the meeting to draw the messages home. So here are just two resources that you can use right away to include the patient and family experience in your work to prevent harm. The second idea that I have for you is actually to partner with patients in the work. So what I have here on the screen is a picture of a website and a link to that website where we celebrate the Patient Safety Champion Awards. The winner of the Champion Awards this year is North York General Hospital, who have identified improvement areas. It's actually related to the NEVER event, but it overlaps with hospital harm. And for every improvement project they created, very similar with how Fraser Health has selected their improvement projects, they created a little team that had a patient partner as part of it. And with that patient partner, they started to set their objectives, their targets, and the actions and the follow-through. So here's just one real-life example of how North York General Hospital has done this. Go on this website and read more about what they have done and how, as well as others. We have lots of good practices listed here. And finally, this is another picture of a website. It's the Engaging Patients in Patient Safety, a Canadian Guide. This comprehensive web-based resource has 4 chapters that will guide you as well as give you very practical tips on how to engage with patients as partners at the point of care, as well as at the organizational and system levels. We do also have a chapter on how to evaluate patient engagement if that's of interest to you. You will also find practical examples and complementary resources and links to the Canadian Foundation for Healthcare Improvement Patient Engagement Resource Hub, as well as social networks on LinkedIn and Facebook, where you can actually bring up issues or questions or ideas or success stories that you have related to patient engagement. The link to the guide is also on this page. So what I had for you today is basically 3 ideas for engaging patients, or tips. 1, go to the Hospital Harm Improvement Resource and use what's available there. Secondly, bring the patient voice in your project as storytellers, include their experience in your work, and even better, bring the patients as partners in your journey, because there is nobody more passionate about preventing harm than patients. Donna told us why this is important to patients and families, and I can tell you from working with over 70 members of Patients for Patient Safety Canada that what drives them, why they volunteer for over 10 years, like Donna, with hundreds of volunteers hours every year, is they just don't want anybody else to suffer the way they've done. So, Kevin, you mentioned that you need to start with the most passionate people, and I would argue that the most passionate people are patients and families. It's not 1 in 18. It's Vance in 18. It's Mary in 18. Actually, if all of us, it's over 300 people on the line now, would be accidentally in a hospital, finding ourselves in a hospital now, over 20 of us would be harmed, and that's just not acceptable. So on behalf of all the patients and families in Canada, I would encourage you to do everything you can to save one more life, to save one more person from harm and from suffering. And I also want to congratulate you, because you have already started this journey. All over 300 of you on the line today in the initial slide told us that you are already on this journey. So congratulations and an encouragement to keep on doing that. Carla, over to you.
Thanks so much, Ioana. Much appreciated, as always. And as I was listening to you speak and reflecting back on Donna's conversation, and now we have some time aside for questions, so please do enter your questions into the chat box or comments if you have any, and tap into these wonderful resources we have on the line today. But Ioana and Donna, I'm wondering, what's your perspective or your observation, say, with regards to patient engagement and the changes in the last, I'm going to say 5 years? What are you seeing? What's happening out there?
Well, for me, this is Donna speaking. I see a great increase in patient engagement over the last 5 years. You know, yeah, it's just tremendous. I mean, Patients for Patient Safety Canada, our organizing or our program alone, has so many requests that we can hardly fulfill them. And it's not just to give presentations at conferences and whatnot. It's to plan those conferences. It's to sit on working groups where policies and procedures and, you know, everything to do with healthcare is developed. So we are invited to attend and as full partners, and that's so very important too. It's not just tokenism, which, you know, at the beginning of this journey, I would say sometimes it was tokenism. It was a check mark because, you know, yes, we are including or engaging patients and families, but it's a much more strategic and deliberate choice to include patients and families and to really hear their voice and to learn from their experiences.
That's great to hear, Donna. Do you have any perspectives, Ioana, from a systems perspective that you're becoming aware of?
Yeah, I can say that all across Canada, not within Patients for Patient Safety Canada, there's more patient groups. There are more patients who are willing to volunteer their time to be partners. And I'm also very much aware of success stories of how this partnership actually resulted in safer care. It's not always easy to make a very straightforward correlation between we engage patients and now, because of that, care is safer by this much. No, that's not possible, but it is possible to see how attitudes, behaviors, and actions change. So patients are indeed great partners in helping us articulate better what matters to them so we can serve them better.
Wonderful. Thank you. We'll continue to leave the chat box open there if you want to enter any questions or comments. Here's a great opportunity to do so. I'm now going to turn it over to Chantel Corris from the Canadian Institute for Healthcare Information to give us any updates on the hospital harm measure. I'm sure we'll look forward to that from Chantel.
Thank you, Corina. Good morning or good afternoon, everybody. So my name is Chantel Corris. I am the manager of Indicator Research and Development here at CIHI. My role is essentially to supervise the development of new indicators for CIHI, and the hospital harm indicator has been in my area for some time now. So we've been working on that indicator for many years, and we had the opportunity to work very closely with facilities and different jurisdictions to validate the indicator over time. And the latest, like the first time the information was publicly available was through the report as of last fall. And we have been receiving feedback since the report was released, and we also had the opportunity to share an updated version of the indicator back in April 2017, and we were particularly interested in having some information from the different jurisdictions and facility on the risk adjustment methodology that we have been developing. So this was ongoing until the end of August, so we did receive a lot of feedback from the different jurisdictions and facilities. We are still receiving some questions and some feedback right now, so we are currently in the process of summarizing, analyzing, and understand how we could use that very valuable feedback to somehow adjust the methodology, and this will definitely guide our strategy to plan for the next cycle of release for the hospital harm indicator. So,
wonderful. Thank you, Chantel. We have some questions coming in. I see a question here from Tara, and I'll open up to the panel, whoever would like to take this. It says, do you have any questions for how to layer hospital harm improvement data with other sources of patient safety information, such as voluntary safety reporting? I wonder if maybe a team member from Fraser Health would like to take that one.
Hi, it's Nicole. And so looking at the hospital harm indicators and also our other safety events reporting systems. So we have a patient safety learning system where safety events are actually reported by anyone, by staff or physicians who encounter the event. They report and there is follow-up completed for each of those events. And so those events or incident, patient safety incidents, as well as each one being followed up individually, we take a look at those on a regular basis to look for trends. So certainly any more significant incidences that result in, say, severe harm to a patient or even death, those ones are followed up very closely. But for other ones that may not be as harmful, we take a look at those in terms of our trends. And those are actually factored into, when we go back and we look at our patient safety priorities and some of those data sources, that patient safety learning system information is actually one of those sources of information in looking at how we set our priorities. but as well our sites and programs take a look at those trends every period and report to the board on some of those top 3 trends in their areas every 2 months.
Wonderful. So what I'm hearing, Nicole, it's more than just collecting data. It's actually reviewing the data and taking the time to study it and determine what you're going to do with it. So thank you for that. We have a question here from Yasser as well, and it's directed to Fraser Health. It says, what data resources did Fraser Health tap into when selecting and strategically planning indicators? And do you have any lagging versus leading indicators?
So data resources that we tapped into, so we, if you can, pretty much if you can name it, we tried to tap into it. So we tapped into, right off the top of my head, we did a comprehensive literature review that was led by our library services group because in my personal opinion, library services is the conduit to evidence-informed practice. So they produced a monster list of indicators for us that we basically read and reviewed all of that literature. We used our ministry data from our Ministry of Health. We used CIHI data. We used internal data. If you can pretty much name it, we used those data sources to really kind of create that overarching list of kind of indicators that we were going to review. Yeah, I will let you know it was a bit daunting at first, and we had to go through, and really the work in the first year that I mentioned was quite difficult because we were new at this, and so the list was quite, as I said, daunting, and we had to really go through and pare those down to figure out what indicators really fell into that range of safety, because some of those indicators you'll find fall into efficiency or effectiveness or, other kind of quality domains. And so then to answer the second piece around leading and lagging indicators, yeah, we talk about that within our 6 patient safety priorities, and we group them as like this. Hand hygiene is definitely a leading indicator. So if we perform well on hand hygiene, we reduce UTIs, we reduce pneumonias. With the indicators that Nicole talked about, we reduce our C. diff. We wash spores off our hands, things of that nature, which then leads us into our lagging indicator, which is sepsis. So if we do well on our hand hygiene, we get a positive outcome in our hospital-acquired sepsis rates. So leading are UTI, MedRec, pneumonia, and UTI. Lagging for sure is sepsis.
Wonderful, thank you. And you'll notice in the chat box that both Iwana and Anne have made some references there to some other tools that you may find helpful. You're happy for you to copy and paste those into your browsers to use after the call. And Kevin, I'm hearing, though, that it was an extensive investment of resources to develop this, but I would say as well, looking at your indicator results, like the fruit is definitely evident. I mean, you're seeing these downward trends in each of your patient safety indicators. So, I think it just goes to show that investment will pay off. It may take a while, but you need to keep pushing and pushing and pushing to get the results that you guys have achieved. So kudos to you. We have another question here from Colleen. She's wondering, how do hospitals display their harm results to their staff? And I would suggest that, we can have Fraser Health speak to this, but if you're on the call and you're currently using the hospital harm information and you would like to share in the chat box how you share the results with your staff, please do that and share it with everybody. But with regards to a recommendation by CPSI, I think we know now from evidence that, the more informed people are, the greater outcomes that can be achieved. So we would certainly be suggesting that teams do share their harm results in a very practical way and a consistent way to keep it top of mind so that people are relating their care that they provide to outcomes. So we would encourage all teams to share the hospital harm results with staff at all times. We have a question for Chantel. Jessica is interested in knowing if CIHI has a concrete sense now of the data quality, accuracy, and comprehensiveness given that the indicator is a composite and comes from coded data. So if you're able to share anything with regard to that, Chantal?
So, sorry, I think the question was a little, because the mute on and off got me, I lost track a bit of the question. Do you mind rephrasing? I understand it's a question about data quality.
Certainly will. And I don't know if your audio was challenged. I know mine is. But yes. The question is, I'm interested in knowing if CIHI has a concrete sense now of the data quality, accuracy, and comprehensiveness, given that the indicator is a composite and comes from coded data.
So thank you for that question. It's a very important question, and a question that we hear many times from different stakeholders. So we did have the opportunity to work on the on the CIHI indicator, looking at data quality from different aspects. So we had a re-abstraction study that was published alongside the report on hospital harm last year, and we looked at some specific clinical group where we saw that the data quality was pretty good for some of the clinical groups. So, and that was published, so we can share the link about this report with you, so you have that sense for those specific clinical groups. In working with the different jurisdiction and facility, looking at validating the hospital harm indicator, we also receive feedback from the different facility that we are somehow comfortable with some clinical group in terms of data quality, and for some other it's somehow a work in progress. So definitely part of the process of making this indicator more useful for the stakeholders is definitely to continue to improve the data quality, acknowledging that how the information is captured and collected from the patient abstract, the patient medical chart. This is definitely something that we, for certain clinical group, we continue to work on with our classification specialists and data quality specialists as well.
Thank you for that, Chantal. We have just a few moments left. So I'd now like to ask Karina to open the poll. And we really depend on this information, and we're hoping you'll take a minute or two to respond to the questions in the poll, because it is an opportunity for you to provide feedback on today's webinar, and it does help us with planning for future education sessions. So if you're able to do that, we would be most grateful. While you were doing that, I'd just like to refer you again into the chat box if you're looking for the resources regarding the Hospital Harm Project. Links and other tools have been provided there, and you can certainly see that and refer to that if you're looking for information as well. We're happy to have your emails at info@cpsi-icsp.ca, and we'll help you navigate with any resources you heard of today or any members of our panelist team that provided the presentation. We would be happy to connect you if that would be helpful. So at this time, I just want to say a sincere thank you to you for taking the time from your day to attend the webinar, and I guess most importantly, our panelists, Donna, Nicole, Kevin, Iwana, and Chantal, for sharing your amazing insights and experiences regarding hospital harm and pointing us again to the need to be inclusive in everything we do and do it with passion and look forward to achieving some great outcomes as we've heard here today. And we trust that you are leaving today with at least one practical idea for using your hospital harm data or the hospital harm improvement resource to help inform your quality improvement plan. Thank you so much to everyone, and I wish you a very happy rest of today. Take care.